Hello, everyone. Welcome. Thank you so much for joining Cadio's webinar series. Today, we are so happy to be joined by Dr. Kiara Moore. Dr. Kiara Moore is an assistant professor at New York University's Silver School of Social Work. Her research examines strategies to enhance mental health services for youth during their transition to adulthood. Focused on young people from under-resourced backgrounds who are from minoritized racial, ethnic, sexual, or gender identity groups, she studies how young adults' development and social positions intersect to shape their participation in mental health care. She is working on identifying novel targets and interventions that employ cultural and structural competency to reduce major barriers to treatment. Dr. Moore was recently awarded an NIMH K23 Patient Oriented Research Career Development Award to use most to adapt and test an arts-based program for young adults in community mental health in New York City. Dr. Moore brings over a decade of experience as a clinician to her research and consultancies. She earned her PhD from Columbia University and her MSW from the University of Southern California. Dr. Moore, a pleasure to have you with us today. Thank you so much.
Thank you. Happy to be here. I'm thinking today I'm just going to give an overview of the study and then open it up to, talk more about things that are of interest to the group. So first, I want to just talk a bit about the background and motivations for this study. The majority of my research has focused on behavioral health and addressing barriers that young people with mental health disorders are likely to face in their transition to adulthood. So mental disorders, including substance use disorders, often show up or are first diagnosed during late adolescence and early adulthood. So between roughly the ages of 15 to 35. And so living with a mental illness during this life stage can make it harder to achieve key markers of adult stability that promote overall health throughout our lives. It can be harder to maintain stable housing and employment, complete education. Having a mental health condition is associated with increased risk for criminal justice involvement. There's other indicators, these are just a few. And so these are factors that set the stage for persistent disparities that we see in adults with chronic mental health disorders. So that's kind of where the public health, urgency is around addressing this. There are effective clinical interventions like treatment and other support services that can minimize the impact of mental disorders and support the transition to adulthood. But young adults are less likely to receive treatment compared to other age groups, even though studies suggest they have the highest rates of behavioral health disorders among all adult age groups. And young adults from racial and ethnic minoritized groups can be more vulnerable to mental health problems due to discrimination and structural inequalities, but they are even less likely than young adults who are non-Hispanic white to use formal mental health services. So there's some emerging research, including some of my own, that suggests there are some characteristics that may be particularly important for interventions to improve engagement in mental health services for minoritized young adults. The current evidence says interventions should be developmentally tailored. They should be relevant for a young person's cultural and structural context. They should help a young person build trusting relationships with the professionals and service providers. They should emphasize hope for recovery, and they should increase self-efficacy to adhere to treatment. So that is kind of the focus of this work and where I think it should go. So in the study I'm talking about today, I'm adapting a brief treatment engagement program called Just Do You according to those criteria. And then testing potential adaptations in a pilot trial. So a little background on this intervention. Just Do You uses narrative health communication and expressive arts activities in a brief orientation program. Brief meaning like 2 sessions. And it targets attitudes and beliefs about mental illness and mental health services and service use behavior. But the content of the intervention doesn't explicitly address cultural or structural factors that might impact a young person's engagement in treatment. So that is a focus of the current study, to design additional candidate intervention components to add to Just Do You and hopefully improve it. And Just Do You was developed by Michelle Munson, professor in the School of Social Work here at NYU Silver. It was developed over years with experts and young adult and service provider advisory groups. And it uses things like recovery narratives, making art and listening to music and videos of celebrities who have lived experience of having a mental health disorder. And it's meant to orient young adults to the services available from the clinic where they have initiated treatment. So it's an orientation to the services in the clinic where they have, recently come in for treatment. The intervention is co-facilitated by a clinician and a professional peer. So a professional recovery specialist who has lived experience of using mental health services. And they work together as a team. And for my project, Michelle Munson, who designed Just Do You, is the primary mentor on my career development awards, because obviously we're adapting and testing her intervention. In a previous RCT of Just Do You, it was delivered following like initial intake at 4 different clinics in New York to 121 young adults living with serious mental illness, so primarily schizophrenia spectrum disorders, and nearly all were people of color. The participants were randomized within each clinic to Just Do You or intake as usual. And the clinic programs where Just Do You was delivered in the previous trial are called Personal Recovery Oriented Services, or PROS. And PROS programs provide things like help with housing, benefits, transportation, in addition to like medication and treatment and individual and group therapy. So the treatment environment that the young adults are being oriented to in the prior RCT is like a psychiatric rehabilitation model. And I was part of the research team for the prior RCT. And in that study, we found that at 3-month follow-up, the Just Do You group had significantly improved treatment engagement, and the conceptual model informing the intervention was supported. So the theoretical mediators were all correlated with engagement in mental health services across both conditions. And Just Do You appeared to increase beliefs that services will be helpful, that providers are trustworthy, and it reduced stigma around using mental health services. But the intervention did not seem to change all of the proposed mediators. For instance, it didn't impact self-efficacy or hope, and not all participants benefited. So there's room for improvement there, is what I learned from that. So building upon what we learned in the prior RCT, my current study uses 2 approaches, the adapted framework and MOST. And the point is to design 3 new candidate components that contribute meaningfully to engagement in mental health services, and conduct a pilot optimization trial to assess feasibility and acceptability for the study procedures and the new components that we designed, and to look at any preliminary evidence of effects of the new components on engagement outcomes and mediators at 3-month follow-up. So we plan to enroll 80 racial and ethnic minority young adults who are living with a serious mental illness in the pilot optimization trial over a 24-month period, which started in December. So here is the conceptual model that we developed based on previous work to develop Just Do You and other emerging research, like the research I was talking about earlier. So the focus of my K23 award, which is a career development grant, I should clarify, it's aimed at gaining expertise in systematic adaptation and optimization of existing evidence-supported interventions, with the goal of, being able to make them more effective for specific populations of underserved adolescents and young adults. So that's kind of the training and career development goal that this grant is aimed at, and that the study is situated within that goal. And so in sort of thinking of this study and how it fits into that overarching development goal for myself, one longer term question I have with this research is whether adding any one or any combination of new components can improve the effectiveness of the original Just Do You intervention, specifically for racial and ethnic minority groups. So that was kind of where it was coming from and where it comes from my research goals. And when I first conceptualized this study, it felt a bit different from the ways that I've usually seen most being used. And for one thing, because it's a pilot, so it isn't getting to the optimization trial yet, or to, an RCT phase yet. But also because I'm sort of using it as a tool to learn about ways to adapt and optimize interventions broadly, right? So that is the sort of learning and development piece, and got me thinking a little bit more about what are the things that we need to know to be able to do that effectively. Also, a distinct advantage of using the MOST framework for this study is that MOST prioritizes achieving the best expected outcome under the constraints of a given implementation context. Constraint meaning something that gets in the way of implementing an intervention, like money, resources, time, etc. So considering this is essential for this study, because a significant strength of the Just Do You intervention is its format as a brief orientation program that can be implemented with minimal additional resources in a given clinic setting. And it was originally designed for sort of publicly funded or nonprofit community-based mental health services. So services that do not have a lot of resources. So I think it is especially important to stay focused on that efficiency and smart use of resources in any way that you would try to adapt or change that intervention. Its efficiency made it feasible and appealing to community mental health providers in the prior RCT, for instance. Because in those types of settings, they need to engage ambivalent young people, with very, very limited resources. And they don't have a lot of resources dedicated to that purpose, which is one of the reasons why an intervention like this would be desirable if it were effective. So this pilot optimization trial will enable us to test a systematic process for ultimately selecting an adaptation with the strongest empirical evidence for acceptability and efficacy, and that can be delivered with the most efficient use of time and resources, right? So most is clearly a tool that would facilitate that process down the line. And I think a strength of this study, and something that's very important to me in my work, is that we're using a deployment-focused approach to intervention design and testing. So it's likely to expedite the translation of the research into practice. And I anticipate this will help to increase the chances of developing, a future resultant intervention that's feasible, scalable, and can be disseminated widely in community mental health services. And that's what all of this is for. So hopefully that's what we find. So the 3 new candidate components and their putative mediators were designed in collaboration with racial and ethnic minority young adults who were living with mental illness, and other key informants, including service providers who work with the population and topical experts, which include members of the study team. The new components are meant to explicitly address person-centered cultural and structural content while targeting the proposed mediators of engagement in our conceptual model. And the new components were selected by me in consultation with the research team. And part of the team includes a creative arts therapist, Michelle Munson, the creator of Just Do You, and my mentors on the K-Ward. I think it's also just important to note a big part of selecting, designing the components was that the new candidate components need to align with the theoretical framework and delivery approach of the original Just Do You intervention. So they use narratives, role modeling, creative arts, and are really meant to preserve the fidelity to the original Just Do You curriculum and strategies. So it took a lot of work to kind of do that in the first stage of this study. And AIM-1 was completed last summer. It was a little over a year long collaborative design project. So we produced versions of the candidate components that we felt we hope are ultimately most likely to be acceptable, feasible, and effective in the community mental health setting where we're going to be testing this intervention. Each candidate component was selected based on a lot of preliminary research, but also collaboratively designed through the ADAPT-IT model. So ADAPT-IT, if you're not familiar, is a well-established participatory approach for modifying interventions, modifying evidence-based interventions to be, excuse me, effective with a specific target population. I'm in the process of writing up the AIM-1 study now. So you're looking at an example of the ADAPT-IT process from Wingood and DiClemente as a stand-in. I will at some point have a visual for the paper that's coming out, but it's not ready yet. And so we used these steps that you see here a bit differently. So in this study, steps 1 and 2 were completed in preliminary research, and AIM-1 is comprised of steps 3 through 6. Steps 3 through 6 involved the theater testing of the first draft of each of the new components and then rapid prototyping. So that's a little different than what Wingood and DiClemente have here. So that means that the first draft was the initial prototype, and then feedback from young adults was incorporated into design another draft. And then we theater tested it with service providers and included their feedback and then subsequent draft. So then we take the subsequent draft. So this is like draft, depending on which component, draft 3 or 4, then goes to topical experts and then integrate their feedback and our findings from across all of those theater-tized groups to have our final draft of the candidate components. And so we've got the final draft of the candidate components, designed their respective training and fidelity protocols, and produced manualized versions that are formatted to go along with the Just Do You core intervention as like additional sessions. So it was a lot to do in a year. It took a little longer than a year. M1 was meant to be like 12 months, and I think it was more like 16 to 18 months, but we're still good. I did have at least the foresight and the guidance to build in a cushion of time. It's a 4-year project. So I thought, okay, if we can get through M1 in like 2 years, we'll still be good. And it worked out. So we decided to use a clinic site we partnered with for the previous RCT of Just Do You to conduct this new pilot trial. So the pilot is in progress with Jewish Board Mount Eden PROS program in the Bronx. We chose this site to do it because we have strong buy-in from the clinic director and the supervisors there based on the prior RCT of Just Do You. And they're working with the target population, and they really see a need for a program like this to keep the young adults involved in their treatment. They've been so excited and waiting for us to start the pilot because it's programming, you know, for their participants who don't really get a lot of youth focused programming at all in their rehabilitation program. So even though it's for the purposes of research, from their perspective, you're adding, you know, value to their services just by being there. And so back in October, Michelle Munson and I led 2 half-day trainings with the interventionists and supervisors at the site. And since then, I meet with interventionists weekly at the site for ongoing consultation and to just figure everything out. And we started recruitment in December of 2024. So now I'll talk more about the AIM-2 pilot optimization trial. So we're in the preparation phase of MOST. Some of you might recognize this slide from previous presentations. I didn't offer this. So this is where we can generate the preliminary data needed for a large-scale optimization RCT. We're using this pilot to assess, you know, the acceptability of the new candidate components when they're added to the Just Do You core, and understand what it looks like to implement the intervention in a typical community-based clinic setting. And I'm learning a lot about that right now in these early months of the trial. A lot of things I didn't foresee, but I love that part. I love jumping in and just being like, let's see if this works. And we're also going to learn about the feasibility of implementing the study protocol. I'm also learning a lot about that right now. And being able to, you know, achieve strong recruitment, retention, adherence, fidelity. And these data will inform refinements to the implementation strategies and or the study procedures before moving on to later stages of testing. You know, with the ultimate goal being to develop an optimized engagement program. But this is the part where we really get a chance to see what that would look like to do an optimization trial. And the setting we're conducting it in is one that we definitely would be a candidate for a future trial, this type of setting, if not this particular one. So the study design is a balanced 2 to the 3rd factorial experiment. Each factor has 2 levels, included or excluded, or here it's yes or no. And then we have 8 experimental conditions that represent all possible combinations of the new candidate components. And so all participants receive the Just Do You core component. So that's not really being evaluated here in a model like this, but everyone's getting that, followed by the candidate components they're assigned to receive, if any. And participants will be randomly assigned to one of 8 of these experimental conditions. The eligible age range is kind of broad. So the range is basically based on definitions of young adulthood that you see in the US Census Bureau, and the age range most commonly targeted in early intervention services for psychosis. So nationally, there are programs for early psychosis intervention. They typically range in that 15 to 35-year-old age group. So I say young adult because that's basically an easy way to encapsulate it, but it's a large age group. We're doing 18 to 34. We're not doing anyone under 18, but it mirrors the age group that's typically targeted. So each condition has like a maximum of 5 sessions, but obviously it depends on which condition they're assigned to. The sessions are meant to be delivered once a week, and they last up to 90 minutes, which would be like an hour one week and 30 minutes the next week. So they start with the baseline and then are randomized after that. And so like I would say overall the maximum time spent in the intervention is 5 weeks, but that would only be for the condition that gets all of the candidate components. I'm monitoring treatment fidelity by having interventionists use session checklists. So they record which content they delivered, the attendance of each session, and report to me about issues that arise, regarding participants or study activities every week. So I hold weekly supervision meetings with the interventionists to review this, and I'm tracking the data that they give me about fidelity in a separate form as part of our data collection. So we're measuring acceptability based on a self-report questionnaire given to the young adults. We're measuring engagement as a concept from this client engagement and child protective services scale that we've modified to refer to mental health care. And then service utilization at 3-month follow-up is going to be based on participant medical records. So the clinic will let us know how many services a person received during their time in the study. And so we can look at that and see if there are patterns. So we're not hypothesis testing, but this is, I think, the way we would approach looking at these outcomes. So that's the way we're testing it. I will also be interviewing the interventionists and the clinic supervisors, potentially other administrators too, if it seems important to do so, to clarify issues involved in feasible implementation of the study. So, the degree to which we are impacting the clinic and the services they provide, hopefully positively, but if there's anything negative, we would want to know. Doing this at 3 points. So I'm interviewing staff and interventionists. I started in the very beginning of the study. there will be a midpoint, and then there will be a final interview. I'm meeting with the interventionists weekly, so probably a lot of things I'll find out about that way. But these interviews are going to be, targeting a variety of staff to kind of get a picture of what we could do better, especially in further iterations, and just kind of help us think about an implementation plan that would be most effective going forward. So for analysis, we're really focused on the acceptability and feasibility. So we're going to summarize with descriptive statistics. And then for the engagement outcomes, it's exploratory analyses. As I said, we're not hypothesis testing. So we're really going to be looking at an overall pattern of change, strength and change in the intended direction instead of hypothesis testing. And then qualitative interviews will be, I think we'll be transcribing all of them and using thematic analysis. It's going to be more of a content analysis approach because we're really focusing the analysis on the way that participants respond, to questions about the intervention itself. I've started doing these interviews now, and I think the protocol is going to change a little bit just to draw out more details around their experience in the intervention. But initially, the interviews are sort of taking an open-ended approach to the acceptability questionnaire that they get after they complete the intervention, and sort of asking them, once they've completed a close-ended survey, why they answered the way they did about those questions. That's what the current interview protocol is for the acceptability. I should have mentioned that. And so, so here's the engagement outcomes slide. More specifically, this is what we'll be looking at, but again, it's exploratory. And these are some examples from M1 where we were developing our components. So these are examples of people sharing something about their cultural identity through art with their service providers. I think all of these were made in response to the cultural identity component, but these were in our theater testing sessions, so I have permission to show these to other people. But some folks are just really good at art. There's no way I could have drawn these. One of the things we learned was that some people are very confident drawing and expressing themselves visually, and others are not. So one of the things we did was develop a set of stickers that you can use if you don't want to draw, and color the stickers. So things you learn along the way. I want to stop talking and engage more in conversation. So I would love to hear any questions folks have. I can also look at the chat. And so I can go back and talk more about some of the things I may have skipped over or talked about briefly if they're of interest.
Wonderful. Thank you so much, Kiara. And I'll just tell everyone, feel free to turn on your camera, raise your hand, unmute yourself, or put a question in the chat. Or if you prefer, send a question to me and I can ask it as well. To kick us off, Kiara, one question. Can you clarify whether this is delivered in a group setting? And if so, how have you thought about the group logistics in the study itself?
Yeah, so it's designed originally to be in a group format, but sometimes it's the case that the clinic doesn't have a group of people to run it with. Yet you want to deliver the intervention as close to their, intake at the clinic as possible. So for instance, you got a new, participant, someone who's eligible, someone who's enrolled. We don't want to wait for another person to come in to like run it. So we're trying to navigate this being something you can do with an individual or a group. And in the prior RCT, that happened as well. So we had some experience with that. When it's in a group, it is much more run the way that the other types of services in these PROS, like rehabilitation programs, are run. They provide a lot of group services. So that's the primary modality of these clinics. So they will run it like a group in that case, but they are also doing it with individuals. And since you asked that question, I also want to add something I didn't mention, which is so we did the prior RCT it wrapped up in 2020 at the time where, well, we had to stop it early actually, because you'll probably remember what was going on in 2020. So these clinics have shifted since that time, have shifted significantly to incorporating telehealth. So one of the things that we had to learn in AIM-1 was whether whether it needed to be something that could be delivered via telehealth. And we don't really know exactly how that works. So that's one of the lovely things about a pilot. So some of the sessions are now being done via telehealth and some are being done in person. And I'm tracking that, obviously. So they're doing it, I think when it's telehealth, it's always one individual young adult. But there's a young adult who did, some of the sessions in a group in person, and then got a job, which was great, and could not come for the subsequent week to do one more component. And so they did it via telehealth and said it went great. The person already had their art materials that we give to everyone that's enrolled. So they were able to take out their sketchbook and the pencils and things that we had already given them at home and do it via telehealth. The facilitators said it went great. And I will be doing the follow-up interview with that individual on Tuesday. So I'm going to ask them how that was and if they have any feedback on in-person versus telehealth. But like navigating the mode of delivery where, and whether there's a group or an individual is all part of things that I'm trying to track and capture at this point. There's a lot of moving parts.
Interesting. Can I just a follow-up question? Does that mean in looking ahead to a powered optimization RCT, are you thinking that you'll have to choose one of those, the sort of group in person, individual in person, telehealth, individual as a strategy? And how are you approaching that decision making based on the information you're tracking?
I think that that's where we might have to go. So it might be that we have more conditions where we test those different approaches. I mean, the long-term goal still ultimately would be to design something that was flexible based on the needs of the service providers and the needs of their patients. So we need to know, what is most effective and efficient, but it's also the case that that could change depending on where it's being implemented and with whom. So these are things that have to go into the thought process that I wasn't even prepared to deal with when I wrote the grant, for instance. So it's the stuff that comes out when you're doing deployment focused work. And I also think with the young adults, a lot of people believe, I don't have data to support it either way, that the remote or telehealth option is popular. We're actually finding it's not at the clinic where we're working right now. They prefer to be in person. So, but it has to be on the table. So it's something that we have to study and we have to think about.
Yeah, great. Another somewhat related question. Can you say a little bit more about the clinics that are implementing Just Do You, or the clinics that you anticipate implementing this intervention, and what kinds of clinics they are and how many there are, and some of the sort of scalability considerations you might have taken into account?
Well, it's designed for community mental health. So those are these sort of clinics that would be, probably funded by nonprofits or especially by government, services, Medicaid, um, and Medicare all over the country, but they have different formats, different ways that they engage with patients. So thinking about next steps, I would want to keep it to clinics with programs similar to the one we're working with right now, just to keep that level of variability controlled. But I feel that there's a wide opportunity to think about the implementation side and what strategies you need to make it widely scalable. I don't
Mhm.
have numbers on how many exist, but it's all over the country, every single state,
Mhm.
every city, every large city,
Mhm.
I should say.
And have you thought, just to introduce extra complexity, because it sounds like that's what you need, have you thought about, you mentioned the impact of the components on the clinic itself. Have you thought about this in a multi-level way, such that there are clinic level outcomes that become relevant?
Yeah, I just can't address that with the pilot, but we will be finding out what that might look like. I think, well, one of the studies I'm hopefully going to be attempting to get funding for over the summer is to collect some data from uh, similar programs in New York and in California that I'm familiar with to try to get a sense of what the differences really are in programs that serve this population, um, in terms of what kind of like clinic level impact we would have from their perspective, and also just from the perspective of organizational change that would need to occur, the degree to which they have the capacity to like run a study for one thing, but also to utilize a program like this. Yes, multi-level, many levels.
Mhm. Great. I'll just give it a moment to encourage people. If you want to, again, you can raise your hand or unmute.
Well, I'll take advantage of this, Kiara. I noticed that there are a number of early career and trainee folks on our webinar today, and I'm wondering if you might have some hot tips for the grant proposal that you wrote, and what would you change about the scope of your project or the approach that you adopted, and just looking for some of your sage advice for those who are possibly currently writing something similar.
Simple question. I mean, I think that one of the things that I think, and also hear from a lot of people with Ks, is like the scope was too much. That it is like a career development grant, and so I could have done less than I'm doing. On the other hand, I am really, interested in this deployment focused work, which is naturally like more complicated because I'm doing it in a real world setting, managing all the conditions that people are assigned to. So I think it's really, really useful to think about what is it that you need to do at this stage. And that is something that these grants are reviewed for. So I guess being overly ambitious was rewarded here, but there's a world in which I may have been able to get this grant by doing less. Um, yeah, I mean, other sage advice, read
What about,
every K that you can in your area of, study.
I think that's good advice. So as predicted, I do like there are people writing this right now. And so you happen to have some very specific mentors, one of whom is definitely on the screen right now. And some, senior the model developer, senior folks who have certainly adopted most and applied it in their work, if not developed it. But could you give some tips for early career folks and like what you would suggest in bringing this to their mentors and how to like anticipate some of their reactions to the innovation of this approach and the novelty of it?
Hmm. Yeah, I didn't have that problem.
I
So,
know, but
I mean, it has to fit your goals. So you want to really make the argument for how it fits the goals of, for a K, the goal is career development and getting you to, the point where you're an independent researcher, et cetera. So how does it get there? Why is this the thing that you need to do? And the innovation is the big part of it. It's like this is a tool that can be used in so many ways. I think one of the ways that I've thought about it was like, I don't want to be out there in the intervention research world without having a firm grasp of most. Like it feels it feels necessary to get to the next level. So when you're thinking about training, it's training you need to have. Um, yeah, I mean, even if you're not embarking on a career where you want to do a lot of optimization trials, still it should be under your belt if you're an intervention researcher.
I'll put that on a t-shirt, I think. But so I think this is really helpful. And specifically those of you who are writing these kinds of things right now, please don't let me hog the mic, so to speak. But so in your grant, you obviously had the most emphasis. Did your mentors have the same like embracing, I don't know what perspective of the adapt it framework? And if not, or if, I don't know, but what were some of the challenges maybe with that? And what strategies did you take to say, no, this is really the right thing to do?
And I didn't have that problem.
Okay, well, you lucked out, my friend.
It just was it's like very like common approach in people in my discipline.
Yeah.
It's just very, yeah. So it was kind of it felt very natural and it was something people are familiar with. And now I'm seeing it like even more than when I first decided to incorporate it. So it's, and also I think both most and adapt it, at least to where I was submitting my K, which was to the services and intervention research group at NIMH. Those things are very familiar to them. So just knowing that at least the folks inside would be very familiar with these approaches because they fund other people that use them. So I feel like that's sometimes an argument because the goal is to get the grant. So
Yeah.
do what works.
I will cede the floor. Thanks.
Thanks, Kate. Kiara, follow-up question in the chat. What was the hardest part of the adaptation process as you've carried it out so far?
It's a lot of work. It's, three components that are different from each other, but dovetail with the original, intervention and with each other, that don't overlap too much, but that makes sense together. I feel like it was just a lot of work. So like AIM-1 could have taken 3 or 4 years to do. Um, and I feel that I was well positioned to do it more quickly because I had been working on this for so long. I had been involved with the intervention, with the original core intervention for a long time. But I think that typically that process would take longer, um, would be its own grant, you know. I know people are doing that with like R21s, and that's 2 years, but I think it should be its own long-term grant. So the hardest part is just it's a lot of work and you're trying to do it rapidly. In the case of the prototyping, I want to incorporate the feedback, and I want to come back to my participants in short enough time where they remember kind of the context and can respond to how it's changed. Um, but I could have spent a year working on just one of the three. Um, so if you're working on something more complex or you don't have as much of a background in it, anticipate more time for that in your project.
Great. Can you say a little more about how you identified the interested parties that were involved in the prototyping process and gave you
Yeah.
input?
Yeah, so we reached out to people who had been involved with the prior RCT and developing the original intervention first, um, because they would be in a good position to kind of understand how this could fit in to that intervention. So we had service providers who were a couple of them were people who facilitated the Just You intervention in the prior RCT. So they had been, fully trained and delivered that intervention for like 2.5 years. So talking to them and showing them prototypes of additional sessions was really useful because they could picture exactly how it could or might not, fit or work. They were also able to give us feedback on, whether they thought it would be meaningful or, useful, and what it would look like from a facilitator's perspective. We also had a group of 15 young adults who were people of color living with a mental illness, and people who had received services in the PROS program where we're testing it. And so they were just responding as if this was an intervention that they would receive. So if you were brought into this as an orientation group, you know, how would this, what would you like? What would you not like? So I think those were the original participants that were recruited for AIM-1. And then after that process, our experts were all of the mentors on the clinical side. So Dr. Doris Chang, Maria Guads, Michelle Munson, and then we also included a couple of service providers who work with this population in similar recovery and rehabilitation programs in New York, who are like clinical supervisors. So they were able to talk about some of the ways in which it might be difficult to do certain aspects of the components in real time. So there were just a lot of different angles there. But I didn't even mention this part. One of the ways that we did the theater testing was we made videos demonstrating, meaning me, demonstrating the component, delivering a component to my research assistant. Very low tech, but really effective. And so we could send the videos out to our participants to like critique and give feedback on. And they actually filled out a little form, and then they did a follow-up interview with me, or a focus group in some cases. For the young adults, I think we almost all of them were in person with us in a sort of focus group or one-on-one when we did the theater testing. But for the professionals and the experts, they got these videos that we made, which was really useful. And I kind of thought of it kind of on the fly. I had not planned to do that. But it was very useful. Sorry, we're really running out of time. Okay.
Yeah, I'll pause and again open the floor to anyone with a last minute question. And if someone doesn't jump on the opportunity, I'm dying to ask, in that process, did you ever encounter differences in people's opinions about something that you then had to sort of adjudicate yourself? Like, did people have very different perspectives on things, and how did you approach that?
Yeah, so that was part of the sort of final draft process. And that was down to me, Michelle Munson, Mario Guads, and our research assistant, who's a clinician and a fine researcher himself, Aaron Rodwin. We sat down and hashed it out. So that's what's going into the forthcoming paper on AIM-1, is that process. We, at some point, we have to make decisions, and basically they're guided by our goals, but sometimes it isn't clear, so we're going to learn a lot. But one example is just, uh, one of the components, the one for structural context, is mapping your environment. And the original tool that it's based on asks people to focus on barriers in their environment to their healthcare goals. And I kind of thought that was a little limiting. I also wanted to look at facilitators in their environment and have them kind of focus on both. But then when I took this to the young adults, some of the young adults were like, focusing on the barriers is actually making me feel worse and not feeling capable of navigating them. When I showed it to the service providers, a lot of the feedback was, you should focus more on those barriers because those are things that we should troubleshoot in the session. And so we had to decide. And we came down on focusing on the barriers because, in terms of the behavioral intervention piece, that's actually the most important thing. And to actually work with the young person to like actually address those barriers in real time was the priority. But yeah, so that will be covered in the forthcoming paper, because
Awesome.
we'll be transparent about that process.
Can't wait to read that and hear all about it. Well, thank you again, Kiara, for a super, super interesting presentation and for all of your wonderful insights about this. And thanks everyone for joining us.
Pleasure. Thank you.